I'm John Cooke, Professor and Chair of the Department of Cardiovascular Sciences. And today we have a very special presentation, a very special guest, Dr. Mark Creager. Dr. Creager is an internationally recognized expert in vascular medicine and former president of the American Heart Association, and has done a lot for vascular medicine through his work with the American Heart Association and the American College of Cardiology. Dr. Creager trained at University Hospital in Boston, and from there he became an assistant professor at the Brigham and Women's Hospital, where he spent most of his career, 30 years at the Brigham and Women's Hospital, doing vascular medicine, taking care of patients with vascular disease, and doing cutting-edge research in vascular medicine. His work primarily focuses on the effects of risk factors on endothelial function and peripheral arterial disease. He's also done clinical trials, multi-center clinical trials in peripheral arterial disease, and has taught us a lot about that condition and the pathophysiology of peripheral arterial disease. Today, Dr. Creager is speaking to us from the Dartmouth-Hitchcock Medical Center, where he is a professor at the Geisel School of Medicine and the director of the Heart and Vascular Center there. Welcome, Mark.
Well, thank you, John. And good morning, everyone. Let me share my screen so you could see the slides.
And Mark, while you're doing that, let me just remind everybody that you can join this meeting by text. Text DeBakey to 37607, and then text in your message. Dr. Creager and I will address those questions that you come up with. You can also join by web. You can go to pollev, that's POLLEV.com, and enter DeBakey and respond to that activity. And Mark, before you begin, one last question for you. Your current research is in peripheral arterial disease and endothelial function. Tell us, before you start, a little bit about that, what you're doing in your research.
Well, John, as you know, I recently moved, not so recently, 5 years ago, I moved to Dartmouth-Hitchcock Medical Center here in New Hampshire to direct the Heart Vascular Center. And with that, took on a huge amount of administrative responsibilities. So my research focus now has actually broadened, because now I'm overseeing a research program for our entire center. Mm-hmm. A lot of the work we do here is actually in outcomes research and health policy. And I have a wonderful faculty covering the whole cardiovascular waterfront, but are focusing in those areas, and the areas range not only from vascular diseases, where we're particularly active, but also a number of particular cardiac diseases, including heart failure and areas of arrhythmia. And we're focusing on the rural population, which is really what who we most encounter here. Mm-hmm. So a lot of the work is now looking at using large databases like the CMS database, and trying to get a better understanding of how our population is doing, what the outcomes are, and how interventions on a broader scale are favorably affecting their cardiovascular health.
That's spectacular. Thank you, Mark. Well, I'll let you go segue into your talk on medical management of peripheral arterial disease. It's about life and limb.
All right, thank you. And that was a very kind introduction, John. But you've neglected to mention that you and I actually have known each other since we were together at Brigham and Women's Hospital, beginning actually over 30 years ago. And it's been a great run, and I'm delighted to see how well you have done and how well things are going at Houston Methodist. I also want to convey to everyone who's listening and watching my heartfelt concerns about what you've had to endure over the past several weeks. I really hope things are getting better. It sounds like they are, but I can only imagine how difficult it has been for your population.
Thanks, Mark.
As was mentioned in the introduction, I don't have any conflicts of interest relevant to this presentation. However, I will be mentioning one or two drugs from a research perspective that have been looked at in terms of outcomes of peripheral artery disease, but are not necessarily approved by the FDA yet for that indication. So let me begin. We'll go back over a century with a quote from William Osler, who said, "Life's tragedies are usually arterial." And that was quite prescient. And I would submit that that statement is as true today as it was back in Dr. Osler's era. We're going to focus on peripheral artery disease today. And I know this audience is quite knowledgeable about it, but let me just set the stage by what I mean by peripheral artery disease. So I'll define it for the purpose of this presentation as the presence of a stenosis or an occlusion in the aorta or the arteries that supply the limbs. It's usually caused by atherosclerosis. That's not always the case. It could be in situ thrombosis, embolism, vasculitides, but for most circumstances, certainly what we'll be talking about today, it's the atherosclerotic peripheral artery disease. And because atherosclerosis is a systemic problem, often affecting the coronary arteries and cerebral arteries, it's associated with an increased risk of cardiovascular death, myocardial infarction, and stroke. And specifically relevant to it's affecting the limbs, patients are oftentimes symptomatic in terms of the classic intermittent claudication, where calf discomfort occurs with walking, but it also may simply impair walking without the typical symptom of claudication. And in worst case scenarios where the blood supply does not meet the resting metabolic needs of the tissue, it can cause critical limb ischemia where the limb is in jeopardy, ulcers or gangrene may occur, and the patient is at increased risk for leg amputation. This is not uncommon. In fact, it is quite prevalent, not only here in the United States, where it affects anywhere from 8.5 to 10 million adults, but across the globe. It's estimated to affect 202 million individuals. As with other forms of atherosclerosis, the prevalence increases with age. The socioeconomic conditions of the country really does not impact as much the prevalence as it does the distribution between men and women. The prevalence is high in high-income countries, and it's similar between women and men. In low and middle-income countries, the prevalence is actually higher in women than men at most ages. The incidence of death and disability attributed to peripheral artery disease has been increasing over the past decade or more, and as exemplified here by 30% between 2005 and 2015. As all of you know, there are traditional risk factors for atherosclerosis and peripheral artery disease. People who have other manifestations of atherosclerosis, such as coronary disease, are at increased risk of having peripheral artery disease more than twofold. And the modifiable risk factors, cigarette smoking, diabetes, high blood pressure, high cholesterol, are all associated with an increased risk of peripheral artery disease. Of these, the major culprits are cigarette smoking and diabetes, which increases the risk anywhere between 70% and twofold. So one of the reasons I'm talking about this today is because of the significant adverse prognosis associated with PAD. And as I already mentioned, it's frequently associated with coronary disease or cerebral vascular disease. And because of that, is associated with an increased risk of death. If we look at a meta-analysis of 16 studies that have examined the relationship of the ankle brachial index, which is an index of peripheral artery disease based on the pressure measured at the ankle versus that measured at the brachial artery, and if it's below 1, it's indicative of peripheral artery disease. Those studies demonstrated that individuals who have an ABI less than 1.0 have an increased risk of mortality. And I'm using my pointer, I assume that's coming over, but just a modest increase in ABI down to 0.8 to 0.9 is associated with a twofold increased risk of death, and a more substantial lowering of the ABI down to less than 0.6, which you often might find in patients with critical limb ischemia, is associated with a fourfold increased risk of death.
Mark, can I ask a question about that figure? If we can go back to that for a minute. It looks like something interesting is going on there as the ankle brachial index increases. There seems to be a slight increase in mortality. Can you tell us what might be going on there?
Okay, so let me just again redefine what the ankle brachial index is. It's the systolic blood pressure measured at the ankle divided by the systolic pressure measured at the brachial artery. It should be 1 or more, slightly more because of pulse wave augmentation. If there's a stenosis somewhere in the aorta or the arteries going to the limb, the ABI will be less. But sometimes, since we use a cuff to measure the pressures, the systolic pressure, there's calcification. And as all of you know, you can inflate the cuff all the way to the top of the manometer and sometimes not be able to compress the artery and obliterate the systolic blood pressure. So an ABI more than 1.4 is actually indicative of vascular calcification. That occurs in people with diabetes. It occurs in people with chronic renal insufficiency. It also occurs with aging in many, and is oftentimes associated with atherosclerosis. But so an elevated ABI is consistent with vascular calcification, indicative of a comorbidity, which in itself is associated with increased mortality. So let me go on. And again, I still want to focus for 1 or 2 more slides on prognosis. This is data from the REACH registry. The REACH registry was a worldwide registry of over 68,000 outpatients. They're all over 45 years of age, who have established cardiovascular disease, either peripheral artery disease, cerebral vascular disease, which is CVD, or coronary artery disease, or at least 3 risk factors. And if you look at the bar graph, in yellow is the 1-year event rate for a composite of cardiovascular death, MI, stroke, or hospitalization. In patients with coronary artery disease, it's 15%, not surprising to any of you. For those with cerebral vascular disease, it's 14.5%. But in those who entered the study primarily with the diagnosis of peripheral artery disease, it's even higher than that. That indicates, at least to me, that PAD is a marker of systemic and often severe systemic atherosclerosis, which is responsible for this increased composite endpoint. In fact, it turns out that about 25% of patients with PAD have a history of MI, 30% angina, 16% of prior stroke, and 15% of previous TIA. We also get additional prognostic information regarding limb vascular events from the REACH registry, and this is 4-year outcomes among patients with peripheral artery disease. 18% will undergo a peripheral revascularization, typically for disabling claudication or critical limb ischemia, and almost 4% have limb loss. Having peripheral artery disease and undergoing a revascularization procedure, which is often limb-saving, really also targets an individual that we need to recognize as having increased risk of adverse cardiovascular and limb outcomes. If you take this data from Connie Hess, who looked at over 381,000 revascularized patients in what she called the Premier Healthcare Database, which is inpatient and hospital-based outpatient visits. She found that 1 year after a peripheral revascularization, 10% of patients still had major adverse limb events, needed another revascularization, or lost their limb. Almost 13% had a cardiovascular event, such as MI or cardiovascular death. Close to 40% were hospitalized during that year, and another 11% had outpatient endovascular revascularizations. So PAD is really a marker for systemic issues, cardiovascular events, and it's for future limb events as well. So all this really underscores the fact that we need to detect and identify peripheral artery disease early, institute mitigating measures, which I'm going to talk about, and hope to forestall many of these end-stage events. This group in particular, I just want to highlight, and that is patients who have diabetes. And I mentioned earlier that it's associated with a markedly increased risk of peripheral artery disease. But the prognosis is also quite concerning in patients who have both peripheral artery disease and diabetes. This is from the Dartmouth Atlas, and looking at a CMS database of Medicare patients. It shows you the risk of amputation in all the Medicare patients in this particular database, so people 65 years of age and older. Those Medicare patients who have diabetes, the risk of amputation per 10,000 Medicare patients goes up. Add onto that diabetes, add on peripheral artery disease, it goes up further, so it's 24 per 10,000. And then if you particularly look at high-risk populations, including African Americans and those living in high-risk regions, typically socioeconomically deprived, the risk of amputation is really quite staggering. It's 35 per 10,000 Medicare patients. And a lot of the problem in that last group, not only from the diabetes and the severe atherosclerosis associated with that, the foot ulcers that occur with that, but also the fact that these patients, both those who are Black and others living in high-risk regions, again, socioeconomically deprived, are not getting adequate access to care, and they're not getting the care they need and the preemptive revascularizations that would forestall an amputation. So part of the problem that we're all facing is that the public doesn't know much about peripheral artery disease. The term is not well recognized. The use of the acronym PAD doesn't mean much to anybody. And when we did a survey now over a decade ago, so it was a survey across the United States, it turns out that 3/4 of the individuals we surveyed had no idea what peripheral artery disease was. So just 1 in 4 really had some understanding. This is kind of highlighted in a Wall Street Journal article that now goes back a decade by Laura Landro, in which she interviewed Rick Peterson, who's a 71-year-old retired social worker in Minnesota. He was diagnosed with peripheral artery disease in 2006 after walking 4 blocks up a hill and feeling excruciating pain in his leg. He said, "I thought it was a bad Charlie horse, so I sat down to have a smoke and the cramps went away." So, tongue in cheek, that there's some humor there, but actually it underscores the fact that people don't know about peripheral artery disease. And because they don't know about it, they frequently don't ask their clinician. And unfortunately, clinicians don't always have a good sense of what peripheral artery disease either. So both of these issues, limited public awareness and sometimes limited clinician awareness, often delays diagnosis and appropriate treatment. When we talk about treatment for peripheral artery disease, I really put them in 2 general buckets. Those we do for cardiovascular risk reduction, antiplatelet therapy, statin drugs, antihypertensive therapy, smoking cessation, all these things you would typically do for coronary artery disease as well. And then focusing on the limb, treatments that will improve leg symptoms, improve the walking distance, limit the symptom of claudication, and then for those with the most severe peripheral artery disease, preserve limb viability. And though these include the drug psilocybin and exercise training to improve functional capacity and revascularization to also improve symptoms but also preserve the limb. So how are we doing? Not well. I'm going to show you 2 studies. This one from Jeff Berger and colleagues, published a few years ago in JACC, where he and his colleagues looked at the prevalence of medication use and lifestyle in patients with peripheral artery disease alone, or those who had both peripheral artery disease and coronary artery disease. So it's based on almost 2,000 outpatient visits of patients with PAD from this National Ambulatory Medical Care Survey and National Hospital Ambulatory Medical Care Survey, which is a nationally representative assessment of office-based and hospital-based practice. So in blue are the patients who only have PAD, and in the orange color, it's the patients who are known to have both PAD and coronary artery disease. So if you look at orange, about in this survey, 55% were on antiplatelet, 45% on statins, look all the way to the right, 60% were counseled about smoking cessation. That's not great, but it's a lot better than the patients who only had PAD alone. By comparison, for those who only had PAD, only 30% were on antiplatelet agents or 30% on the statin, and only about 30% were getting smoking cessation counseling. And you can look at the other bars as well. So knowledge of PAD among physicians is not triggering those risk factor modifying interventions that are needed to preserve a patient's cardiovascular status, cardiovascular health, and their limb as well. Here's another study published more recently by Colantonio. This is looking at a much larger database of over 940,000 patients with commercial or Medicare health insurance. Took place several years ago. And it's grouped about among patients who have coronary artery disease, here coronary heart disease, cerebral vascular disease, which is CVD, and PAD, either in isolation or altogether. So if a patient is known to have, and this is about statin use, if a patient has all three vascular conditions, almost 60%, 56.5%, we're getting a statin. A lot less than that, we're getting a high-intensity statin. That's on the right-hand side of the panel. If you drill down and patients only had known coronary heart disease, about a little bit more than 50% were getting a statin, and a little bit more than a quarter, perhaps, were getting or 30% were getting a high-dose statin. If you go all the way down to the bottom and look at the PAD only, that black bar, only 34% were being prescribed a statin, and really a little bit more than 15% were getting a high-intensity statin. So another study confirming the fact that PAD, even when known, is not triggering appropriate medication use. In the previous slide showing a group of medications, this slide statins alone. So let's look at the data. I mean, why even push the use of lipid-lowering drugs unless there's data to support it? So let me talk about the data. I'll start with lipid-lowering drugs, and then I'll go into some antithrombotic therapy, and these are clinical trials. So we can go back almost 2 decades now to the heart protection study. So I think most of you remember this study. It was one of the first large studies looking at the efficacy of statins in patients with atherosclerosis, either coronary disease, cerebral vascular disease, peripheral artery disease, or diabetes and multiple risk factors. And the patients were randomized to simvastatin or placebo. And there's well over 20,000 patients in the entire study. And what I want to show you first is that it worked, right? If you looked at all the patients in the study, there was over 20% reduction in the risk of adverse cardiovascular events. But that applied to the peripheral artery disease patients as well. So that's highlighted in orange, where they had over a 20% reduction in adverse cardiovascular events. The reason I showed this to you is this is the first study that actually culled out a PAD group and showed the benefit of statin therapy for adverse cardiovascular events. The REACH registry, which is an observational study, which I alluded to previously, I'm showing you this slide to focus on the limb events. So among the patients with peripheral artery disease in the REACH registry, those who were on a statin compared to those who were not had a decreased risk of worsening claudication or new critical limb ischemia, a decreased risk of needing to undergo a new limb revascularization, and a decreased risk of needing to undergo an amputation or limb loss. Other studies would support the notion that statins are effective not only in cardiovascular events, but limb events. This is from Shripra Arya, looking at a VA database of over 100,000 patients and looking at whether they're not on a statin, even though they were on an antiplatelet medication, but not on a statin, or in a low to moderate intensity statin or high dose statin. On the left-hand side is mortality, and the right-hand side is amputation. And what this study shows is that those patients who were on statins compared to those who were not had a lower mortality rate and a lower risk for amputation. And those who were on high-intensity statins had the lowest risk of death or the lowest risk of amputation. And in a meta-analysis published not so long ago by Cooke and colleagues in vascular medicine, this group looked at patients with critical limb ischemia who were either on statin treatment or not, and their subsequent mortality rate, just dialed down to the bottom part of this slide here, which shows that in this meta-analysis, those patients with critical limb ischemia on a statin had about a 38% reduction in the risk of death. So let's move forward and talk about newer cholesterol-lowering drugs. And here I'm referring to the Fourier study, which again I think most of you are familiar with, which looked at the PCSK9 inhibitor evolocumab and clinical outcomes in patients with cardiovascular disease. So this included patients who had a prior MI, ischemic stroke, or peripheral artery disease. There's over 27,000 of them. They're on a statin, and their LDL cholesterols were at baseline 70 milligrams per deciliter or higher. They're randomized to evolocumab or placebo, and the primary endpoint you see written on the left-hand side is a composite of cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary revascularization. So the trial worked. Evolocumab reduced the risk of this composite endpoint in this population by about 15%. The reason I'm talking about this is because we can call out the PAD group, of which there was 3,642 patients. And that's demonstrated on this slide. So in the upper part of this slide is the PAD patients randomized to placebo or evolocumab. The bottom is everybody else. In each group, as you might expect, there was a significant reduction in cardiovascular death, MI, or stroke, which is the secondary endpoint. There we go. But the magnitude of decrease was greatest in those with the highest risk, and those with the highest risk were those with PAD. And these individuals really enjoyed a 27% reduction in risk, relative reduction in risk, and a 3.5% absolute risk reduction in cardiovascular death, MI, or stroke. So two messages here: addition of evolocumab to a statin to get to lower an LDL lower than 70 milligrams per deciliter is a good thing. And generally, the lower we can get the LDL cholesterol, the better in preventing these adverse cardiovascular events in patients with PAD. The study also looked at limb events, and here I'm showing you major adverse limb events, which is a composite of, in this study, of acute limb ischemia, major amputation, or urgent revascularization, and the addition of evolocumab to a statin compared to placebo, in addition to a statin, was also associated with a significantly reduced risk of major adverse limb events. I'm going to turn now to antithrombotic therapy and divide this briefly into antiplatelet agents and anticoagulants in this overall heading of antithrombotic therapy. I want to first share with you this really interesting pathologic study by Jagat Narula, his wife and colleagues, where they examined the vascular anatomy of patients with critical limb ischemia who underwent amputation. So there were 75 patients. They had 98 amputation specimens. And what I'm showing you here is just a few shots of the pathology that they reported in the study, which was in JACC several years ago. So these are either the popliteal artery all the way on your right, or the dorsalis pedis and anterior tibial artery on the left two panels. What each of these specimens shows is thrombus, not plaque. There is some plaque there, but it's not very significant. But what's happening in these patients with critical limb ischemia downstream in these vessels is superimposition of thrombus, either formed in situ or as a result of an embolic event. And from the central illustration, if you will, of this study, we learn really some interesting things about the pathology of the arteries in patients with critical limb ischemia. It turns out that thrombus is a major player, much more than I think we had understood previously. So if you look at the cartoon on the left-hand side, which shows the femoral popliteal arteries and the infrapopliteal arteries, in the femoral
popliteal arteries, about 25% of them had a stenosis, mostly due to significant atherosclerosis. But in 3/4 of them, there was a lot of thrombus, sometimes in the presence of atherosclerosis and sometimes with not so much atherosclerosis. If you look down to the infrapopliteal arteries, and as I implied in the previous slide, there was a lot of clot, and oftentimes without atherosclerosis. So about a third had thrombi associated with significant atherosclerosis, but 2/3 of the arteries had a thrombotic occlusion without significant atherosclerosis. So I want you to just think about that as we talk about the efficacy of antithrombotic agents in patients with peripheral artery disease, particularly adverse limb events. So aspirin's been studied for years, and we all use it. We use it for our patients with coronary artery disease, and there's a lot of data to support that. One would think extrapolating that data, aspirin would be an effective antiplatelet agent for patients with peripheral artery disease. But there's not been a whole lot of studies that have focused on aspirin. There's only been a couple, but there's been many studies that have included aspirin in their analysis. This is a meta-analysis by Jeffrey Berger and Will Hyatt. It's a decade old now, but it looked at a number of studies that compared aspirin to a control and the endpoint of adverse cardiovascular events. And what you can see across the board is that most of them did not show a significant decrease in adverse cardiovascular events. One of them did by Catalano, but the others didn't. And in the aggregate, the total down at the bottom, there was a 12% reduction in the risk of adverse cardiovascular events, but the confidence intervals crossed one and was not statistically significant. So one has to wonder really how effective aspirin alone is in patients with PAD. And again, it's not just because they have PAD, they often have fairly significant and systemic atherosclerosis. Well, we go back even more than 20 years ago and look at the Capri trial. So certainly of historical interest and still relevant today. Capri was a study of over 19,000 patients with stable atherosclerotic vascular disease, including coronary artery disease, so recent MI, cerebral vascular disease, recent ischemic stroke, or established peripheral artery disease. And in the aggregate, all groups put together, there was an 8.7% relative risk reduction for adverse cardiovascular events. But if you break out the PAD group, there was a 24% reduction in risk favoring clopidogrel over aspirin. So really the first study to highlight what was at the time a new phenylpyridine derivative or ADP antagonist and its efficacy in patients with cardiovascular disease. So let's move forward, a lot more forward, so to 2017, where we see the Euclid trial, which really focused on patients with established peripheral artery disease and was seeking to determine whether ticagrelor was more effective than clopidogrel in these patients in reducing adverse cardiovascular events. This trial was led by Will Hyatt. For those of you who don't know, Will was an outstanding clinical trialist, particularly in the peripheral artery disease area, and unfortunately, he passed away this past December. So this trial, the Euclid trial, compared these two ADP antagonists. The composite endpoint was cardiovascular death, MI, or ischemic stroke, over 13,000 patients, almost 14,000 patients with symptomatic PAD that had a low ABI or previous leg revascularization. They're randomized to ticagrelor 90 milligrams twice a day or clopidogrel 75 milligrams once a day. There's no difference in outcome. The hazard ratio was almost unity. So what I learned from this is that either would be effective if we take into consideration the previous Capri trial, which had aspirin as a comparator. Unfortunately, Euclid did not have aspirin as a comparator. Is more better? So what I mean by is more better is two antiplatelet agents better than one antiplatelet agent. Well, one study that attempted to address that question was Charisma. Charisma looked at aspirin alone versus aspirin plus clopidogrel on standard cardiovascular endpoints of MI, stroke, or cardiovascular death in patients with established atherosclerosis, coronary disease, cerebral vascular disease, or peripheral artery disease, or multiple risk factors. Deepak Bhatt was the lead author on this study in the New England Journal. If we looked at the overall population of over 15,000 folks, there was not a statistically significant reduction in this composite endpoint. But if we cull out the patients like in Capri who had established atherosclerosis, coronary disease, cerebral vascular disease, or peripheral artery disease, there was a 12% statistically significant, if you will, relative risk reduction in this adverse cardiovascular endpoint. Conversely, if you just look at patients with multiple risk factors, it trends the other direction. So this is more hypothesis generating than drawing any conclusions about dual antiplatelet therapy, but it lends credence to the consideration that those patients who have established atherosclerosis might do better, particularly if it's severe, if they're on dual antiplatelet therapy versus aspirin alone. Pegasus was another way of looking at this. This is a TIMI trial. Over 21,000 patients with prior myocardial infarction. They're on a background of aspirin and they're getting one of two dose regimens of ticagrelor. This slide is showing you the no PAD and the PAD group. It's similar in format to a slide I showed you previously. Among patients with PAD, there was a fairly significant 25% risk reduction in their primary endpoint, which is a composite of a cardiovascular disease endpoint, in patients who received ticagrelor plus aspirin versus those who received aspirin alone. There was a smaller, albeit statistically significant, reduction in endpoints in the groups who did not have PAD. Now let's move even a little bit further to what may be our major game changer in the antithrombotic area in patients with atherosclerosis and relevant to this talk and those with peripheral artery disease, and that's the COMPASS trial, published several years ago by the group from McMaster, Eichelblum and colleagues, and really colleagues across the world. So COMPASS is, as I think many of you know, was a study looking at patients with stable atherosclerotic vascular disease. So they had known coronary disease, peripheral artery disease, or carotid artery disease. There was over 27,000 of them. They're randomized to aspirin alone. They're randomized to rivaroxaban alone, 5 milligrams twice a day, or they're randomized to aspirin 100 milligrams a day, plus a very low dose of rivaroxaban, 2.5 milligrams twice a day. The typical composite cardiovascular endpoint of CV death, stroke, or MI. And as you can see in this, in the figure, the patients randomized to the combination of rivaroxaban plus aspirin had a significantly reduced composite endpoint compared to those with aspirin alone. The rivaroxaban alone group compared to the aspirin alone didn't quite make statistical significance. If we focus on the PAD subgroup in this trial, and this is a study published after the primary study was published, this is by Sonia Anand. In this trial, PAD was actually defined as both symptomatic limb PAD and carotid artery disease. Of the patients with PAD in this trial, which was over 7,400, and you can see the grouping on the left. They also consider those who had coronary disease and low ABI part of the PAD subgroup. There also was significant benefit when you look at the combination of low-dose rivaroxaban plus aspirin compared to aspirin alone. In fact, there was about a 28% risk reduction in this adverse cardiovascular endpoint. COMPASS also looked at limb endpoints. Here, they defined major adverse limb events in the PAD group as acute limb ischemia or chronic limb ischemia requiring revascularization. And then in this trial, we're adding on amputation to a major adverse limb event. And once again, you'll see that the combination of low-dose rivaroxaban and aspirin at 100 milligrams a day was much more effective than aspirin alone in reducing the risk of major adverse limb events. So if you think back to that pathologic study I showed you, which really shows a major role of thrombus or embolic events in patients with peripheral artery disease, it begins to make sense that more aggressive antithrombotic therapy may forestall limb events, including the development of critical limb ischemia or even amputation in those who have critical limb ischemia. So I think, as I'll talk at the very end, as we rethink our clinical practice guidelines, it will not surprise me if these antithrombotic regimens receive a significant grade. I should have mentioned this before I summarize COMPASS, but this was the adverse effects in the COMPASS trial, bleeding in particular. As you might expect, when you add antithrombotic agents, even low-dose rivaroxaban, you increase the risk of bleeding. In COMPASS, they looked at major bleeding, which included fatal bleeding and non-fatal symptomatic intracranial hemorrhage. There was a increased risk of that. The hazard ratio was 1.61, but fortunately, there was no significant increase in, if you look at fatal bleeding per se, or some of the other, or even non-fatal intracranial hemorrhage. But we have to be cognizant of the fact that there is a bleeding risk, but fortunately, it was not severe in most circumstances. To carry on the thought of low-dose rivaroxaban plus aspirin, I just want to share with you the results of the recent Voyager PAD trial. This was published by Mark Bernacca, Will Hyatt also this past year in the New England Journal. Voyager PAD was a trial in patients with PAD who underwent peripheral revascularization, randomized to low-dose rivaroxaban plus aspirin or aspirin alone. The major endpoint here, the primary composite endpoint, was acute limb ischemia, major amputation, MI, ischemic stroke, or cardiovascular death. And the findings shown in this slide is that the addition of low-dose rivaroxaban to aspirin reduced the risk of this primary composite endpoint by about 15%. Again, lending credence to the possibility that adding low-dose rivaroxaban to aspirin is an effective intervention in patients with established PAD and in Voyager following revascularization. This is the primary endpoint broken down into its constituents. So statistical power was not adequate for each constituent to really demonstrate anything, but for most of them, there was a trend in the right direction. For acute limb ischemia was statistically significant. Interesting, the part of the composite endpoint, death from cardiovascular causes, was not different between these two groups, distinguishing itself somewhat from the COMPASS trial. These are the adverse effects, the safety outcomes, and bleeding in particular. In the Voyager PAD trial, they looked at TIMI major bleeding as the primary categorization of bleeding. And in that situation, there was, by numbers, a relative increased risk of TIMI major bleeding, but it did not achieve statistical significance. If you look at other bleeding scores like the ISTH major bleeding score, the MARC major bleeding score, it was increased in those who got combination therapy. Now, what's interesting about Voyager, even though this wasn't part of the randomization scheme, because the patients who are, half the patients who underwent peripheral revascularization were getting endovascular intervention. Many of them, as the standard of care, were placed on clopidogrel. So whether or not they received rivaroxaban, both groups, those aspirin alone and those aspirin plus rivaroxaban, often got clopidogrel. Sometimes they did not, and the clopidogrel administration was for up to 6 months. It turns out that the addition of clopidogrel did not affect the primary endpoint results. You can see the hazard ratios are quite similar, nor did it really affect any of the subcomponents of the primary composite endpoint. Moreover, this slide is showing you bleeding incidence in the patients who received clopidogrel versus those who did not, and whether or not they were on placebo or rivaroxaban. And the addition of clopidogrel really didn't affect it. So if they were on the rivaroxaban group, as I already mentioned, there tended to be an increase in TIMI major bleeding and some of the other components, ISTH major bleeding. But the addition of clopidogrel did not seem to affect the magnitude of the impact of rivaroxaban on major bleeding. I just want to finish up in the last few minutes just talking about other therapies we use in peripheral artery disease to improve symptoms or preserve limb viability. I'll start just about cilostazol. There are 2 drugs approved by the FDA for improving symptoms in claudication. One is pentoxifylline, and the other is cilostazol. None of us use pentoxifylline anymore because nobody thinks it works. And really, it was studied well before we really were doing well-designed clinical trials. Cilostazol is a phosphodiesterase 3 inhibitor. It has antiplatelet properties. It actually has some lipid-lowering properties. It has been shown, compared to placebo, to improve the walking distance in patients with claudication. This is a meta-analysis that my group did some time ago, 10 years ago, of 9 randomized trials showing the improvement of about 50% versus placebo, where it's about 20% improvement. So it is a drug available. And when you talk about optimal medical therapy for claudication, it's something you would want to consider. Because it's a PDE3 inhibitor, not unlike milrinone, there is caution advised in patients with heart failure because, as you know, milrinone, although it's effective in improving hemodynamics and sometimes symptoms, it's associated with an increased mortality in patients with heart failure. So there's a black box warning for cilostazol in patients who have PAD but also impaired systolic function or have heart failure. I don't want to forget the importance of supervised exercise therapy in improving symptoms in patients with intermittent claudication. Just like we do cardiac rehab following MI, we do peripheral artery disease rehab in people with claudication. It's typically 3 to 5 times a week, 30 to 60 minutes per session, usually on a treadmill, could be a track. The programs go for 3 to 6 months, and tremendous benefit. I told you there's about a 50% improvement with cilostazol. There's 100 to 150% improvement in maximum walking time with supervised exercise treatment. Here's a quick story by one of my patients. I love this one. I just got back from a trip to Florida's Disney World with my 5-year-old granddaughter. Most wonderful vacation of my life. The joy of seeing her face light up, and all the ride shows and fun in Disney was well worth all the hours I spent exercising. Thank you for giving me back the will to continue walking. This is an intervention that works. There's lots of reasons it might work. I don't know the specific reason, and maybe some are the aggregate of these things. Improved collateral blood vessel development, enhancement and endothelium-dependent vasodilation, better hemorrheology, the one I favor the most, increased oxidative capacity of leg skeletal muscles, or even just better walking biomechanics. All these things, or some of these, are, I'm sure, relevant to the improvement in walking distance. It's been looked at in the CLEVER study. CLEVER study was a trial comparing exercise therapy to endovascular revascularization in patients with claudication and aortoiliac disease. They're randomized to 1 of 3 groups. The red is optimal medical therapy that included cilostazol. The yellow is exercise training, and the green is they got an endovascular stent, typically in their iliac artery. Compared to optimal medical therapy, both exercise training and stenting was associated with improved peak walking time at 6 months. But the impressive thing is that the winner was exercise training, which actually beat out stenting in terms of efficacy in improving exercise distance. The ARRAISE trial actually combined the two. The ARRAISE trial looked at patients with claudication and femoral popliteal artery disease, randomize them to exercise training alone or exercise training plus endovascular revascularization. If you look in that bar that says supervised exercise, comparing the baseline, these patients did great. Almost a threefold or more than a threefold increase in walking distance. But if you add to that peripheral revascularization, they did even better. So in some situations, particularly in patients with disabling claudication, one might consider both an endovascular approach as well as exercise training. A couple of years ago, CMS approved supervised exercise therapy for peripheral artery disease for reimbursement. The program, the acronym is STET, is much what I discussed previously, so I won't restate that. But CMS will pay for sessions to benefit our patients. So what we need to do is make sure that our patients with claudication are getting the rehab, which will improve their symptoms, just as we do with our patients with coronary artery disease. So I just want to close and remind you there's a great resource out there. That's the 2016 AHA-ACC guidelines on the management of patients with lower extremity peripheral artery disease. It should be part of everyone's pocket guides, if you will. And it's a terrific way to look into many of the things I talked about and more in the management of peripheral artery disease. Now, I acknowledge this was published in 2016, and many of the things I spoke about today have occurred since 2016. The good news is that the guidelines are being updated as we speak, and I anticipate that later in this calendar year or early in the next calendar year, we'll see the update. So with that, I'll close. Thank you all for your attention. I'm happy to take any questions.
Mark, that was a superb talk. Thank you so much, and thank you for the good work that you've been doing for patients with peripheral arterial disease all these years. We've got lots of questions. Maybe we can move through them pretty quickly. From Bill Zogby, wants to thank you for a superb presentation. Wish you were here with us in Houston. You touched upon two challenges: lack of awareness and underdiagnosis, undertreatment. Should we do ABIs at the time of calcium scoring in appropriate individuals? What's the concordance or complementation of doing an ABI with calcium scoring?
Right. Well, first of all, hello, Bill. I'm so glad you're here, and I wish I was there meeting with you. Mm-hmm. It's great to know you're here. That's a really great question. And there have been studies that look at that. So everyone is aware of the risk scores, the AHA-ACC risk scores, for assessing potential outcomes in our adult patients. I think similar to coronary artery calcium scores, getting an ABI can enhance our risk prediction, particularly in the intermediate risk category. And probably to a fairly similar magnitude, although the prevalence of an abnormal ABI is not as much as coronary artery calcium. So I would say the answer is yes, not that it should be used instead of, but could be used as another test to refine risk prediction. The American Heart Association, American College of Cardiology guidelines that I just referred to at the end of the talk does recommend ABI testing in high-risk individuals, that is people over the age of 65 or over the age of 50 who are either smokers or have diabetes. Unfortunately, the United States Preventive Services Task Force have not given a green light to ABI screening among our population, and they did not drill down on the high-risk population. They just said there's inadequate evidence to determine whether ABI screening will improve risk assessment and treatment in our population. We have been having back and forth with that group and cautiously and respectfully asked them to modify their recommendation. It has not happened yet. But that has important implications for whether or not CMS is going to pay for ABIs in the office. So great question. I'm hoping we'll be able to do that. I do think it improves risk prediction.
Let's stick with ABI for just a minute because there's two questions regarding subclavian artery stenosis and how that may adversely affect the ABI measurement. So yeah, go ahead. Maybe you could talk a little bit about that, Mark.
All right. So I didn't go into detail about how we measure the ABI, except I mentioned that it's a ratio of the systolic blood pressure at the ankle compared to that at the arm. Well, we actually do it in all four limbs. So both brachial arteries and the dorsalis, pedis, and posterior tibial arteries of each leg. So we get lots of measurements. For the actual calculation of the ABI, you take the denominator is the highest of the two brachial arteries. So as you all know, it should be the same. Sometimes it's not because blood pressure varies a little bit as we move around the body. But if there is a significant difference between the two, like 20 millimeters of mercury or so, implying that there's a subclavian artery stenosis on the lower side, that's not the number we used in calculating the ABI, but it's informative because it tells you there's something going on there, oftentimes atherosclerosis.
Thanks, Mark. In our gene PAD study, we actually looked at that, and a difference between the two arms in blood pressure of 20 millimeters of mercury was an independent predictor for adverse events in our population. That population were patients coming for diagnostic cardiac catheterization, 2,000 patients. So it is an important feature to look at in the patient's physical exam. And some questions, Mark, about thrombolysis. You talked to us a little bit about the thrombus in critical limb ischemia that participates in the disease. This questioner wonders what trials are ongoing for thrombolysis in critical limb ischemia. The question is, can thrombolysis give a better result in patients that have significant critical limb ischemia?
Well, thank you. That's an important question. So what I didn't talk about today was acute limb ischemia, the sudden onset of limb ischemia, typically caused by an in situ thrombosis or embolism. In that situation, thrombolysis has a definitive role, particularly catheter-based thrombolysis. And there's been 3 major studies, but they were done quite a long time ago, which looked at thrombolysis. And there's been varied results across the studies, but it is an option, particularly in patients who have very recent onset acute limb ischemia, where the thrombus is relatively fresh. In chronic limb ischemia, that thrombus is probably pretty socked in there. And the likelihood that would be amenable to a thrombolytic approach is probably quite small. So if you weigh the risk of thrombolysis versus the very low benefit, it's not one that I or anyone else I know would necessarily recommend in patients with chronic critical limb ischemia. The question whether there's any ongoing trials looking at that, I'm not aware of any at this time.
Mark, here's a question that might allow you to talk a little bit about your NIH-funded study of cardiovascular risk and outcomes in urban, or rather rural populations. In your studies, are you seeing that people are doing more life modification to prevent onset of peripheral arterial disease, better diet, exercise? Has there been, with all the conversation that the American Heart Association has been having with the American public, has there been any uptake of those modifications of lifestyle?
In rural populations? No, quite the opposite. In fact, I refer everybody to a great AHA presidential advisory. The first author was Bob Harrington, published in Circulation 6 months ago. We are not doing well in rural populations. Compared to most urban populations, we do poorly. When I say we patients are not getting adequate care, and they're not getting these risk factor modifying interventions, even to the same magnitude. That's not great either in urban populations. And I'm sure there's a lot of reason to this, but to come see me here, some people have to travel 90 minutes. It's a long distance. They don't have the awareness on one hand, and nor are they getting the medical care they need locally to institute these things. And that's what we're trying to do now through a variety of interventions, including telehealth, as you might imagine, to get these people the care they need. But what I'm finding here, and this compares, John, to when I was at the Brigham, when patients show up here in our emergency room with horrible heart disease, really advanced heart disease, or in the case of peripheral artery disease, severe critical limb ischemia, gangrene and ulcers,
they have had long-standing disease, whether it's diabetes, high blood pressure, even the clinical manifestations of atherosclerosis, and unfortunately have not gotten care. And one of the first things they say with great pride is, "I haven't seen a doctor in 20 years." We really need to do a lot better.
Thank you, Mark. What a wonderful presentation, and what a wonderful career you've had. You've given us so much in terms of our understanding of the pathophysiology of peripheral arterial disease and its management. Thank you so much for meeting with us today, Mark, and keep up the great work.
Thank you, John, for the kind invitation. Thank you all for listening, and have a good day.
Bye, Mark.
Safe.